At the outset, I would like to thank you, sir, for giving me this opportunity to be in this course. And like, I'll be speaking many things which I have learned from you, sir. Like, you're a mentor for all of us. And so my perspective on pediatric orbital fractures. So when we talk about the orbital fractures, basically it is a blow-in fracture or a blow-out fracture. The blow-in basically is seen in the case of a roof fracture, especially in case of children. However, the blow-out fracture is more common amongst the adults. So there's a dictum that children orbit are not small adult orbits. And it's very important that we understand that the children orbit is completely different from that of the adult orbit. In children, the frontal bone and the orbital roof fractures are commonplace because there's a very high cranium to face ratio. There's incomplete or absent pneumatization of the frontal bone and also prominent orbital rim. And if you look at this here, this is at birth, where you see hardly the maxillary sinus is being formed. And as the child grows, by the age of 5 years, we have a much pneumatized maxillary sinus, but still incomplete. And as the child grows older, by the age of 14 years, the whole maxilla undergoes pneumatization. And by the age of 16, you can see all the pneumatization of the sinuses has happened. So if we look to this data, the cranial volume to the facial volume at birth, it is 8:1. And as the child grows, the cranium becomes small and the face becomes larger. So by 5 years, it is 4:1. And by adulthood, it is 2:1. There's a very nice concept of the eye tooth, which usually, that is a canine tooth, which usually gets erupted only at the age of 12 years. So this is also considered as a condition or as a factor which prevents or resists the orbital floor fracture, which is usually not seen in the young children. So these are some quintessential examples of how the ongoing sinus and the facial development impacts the fracture pattern and makes it rare to have a typical blowout fracture in a young child. And what we commonly see in a young child is the VEVOF, the white eye fracture, which is basically a green stick fracture and where there lack of any periocular signs, but this can be very serious because the muscle gets entrapped, leading to necrosis, and also there can be oculocardiac reflex. So what is this green stick fracture? This is a minimally displaced fracture which predominates in the children because the pediatric bones are very, very elastic and they deform to elude the fracture. So in general, what happens, the pediatric bones are very cancellar. So this is against the Young's modulus. We know the Young's modulus is directly proportional to stiffness. And because the pediatric bones are less stiff and more elastic, so the pediatric bones can absorb more energy during their impact and can resist a fracture. So in pediatric orbit, we see that there is a splint where there's a network of ligamentous tissue, which usually prevents the prolapse of the orbital contents, even if there is a blowout fracture. But this is usually not seen in the adults. In adults, the splint is much friable, and also whenever there's fracture, the periosteum usually gives way, allowing all the orbital contents to drop into the maxillary sinus. So what is the trapdoor fracture that we see in the children? This trapdoor fracture is basically a linear fracture with the entrapment of the inferior rectus muscle. So what happens when there is a fracture? And the fracture should be quite a severe fracture in order to lead to a blowout fracture in the child. And as such, the rectus muscle gets prolapse in the maxillary sinus. But what happens because of the elasticity, as the trauma force ceases, the bone floor, the bone segment recoils back. But as the bone recoils back, the muscle does not recoil back and remains trapped there, which can lead to serious complications like Boxman's ischemic contracture and also the oculocardiac reflex. So basically in pediatric case, we get a very commonly the trapdoor fracture, which I have already showed you, where you can see the muscle being entrapped. This is the CT and the MRI that you can see here. And the other common is the open door fracture. But the open door fracture is much less as compared to the trapdoor fracture. But we do get open door fracture even in children, especially when there's a road traffic accident, which can lead to a big fracture with approximately 50% of the orbital floor being fractured. So when I talk about blowout fracture, we all know whether it is adult or it's a pediatric, the main theories are the buckling theory and other is the hydraulic theory. So, but the most important thing that though we are speaking about the orbital fracture, if we look to the cranial and the facial part as a whole, the most common fracture amongst the children is mandible, followed by the NOE, which is quite common. And I have seen quite a few of the NOE fracture in children, and then comes the orbital fracture. But how do we classify? There's a very nice classification which came in the PR's journal, which they say the type 1 is basically a pure fracture and which can be graded from 1A to E, and the type 2 is basically craniofacial. But the type 3 is when you have an orbital fracture with other fracture patterns, especially when you have a floor fracture with the inferior fracture, which is a type 3A. Or you can have a ZMC fracture, which we usually call a tripod fracture involving the zygoma, and you can have the NOE fracture, which is 3CE, and also you have the LIFO2 and the LIFO3. So these are basically the fractures we see in the pediatric children, the most common being trapdoor, but also you can see other fractures. And how do we examine this patient? A very detailed history is very important. Go the examination general status, which is most important. Then we go for the local examination, go for the imaging and see whether the patient needs acute surgery or immediate surgery, or we can defer the surgery. These are the classical clinical features which you can see both in pediatric and adult. But the most important in any pediatric case, we need to examine the intraocular examination very well with a very good evaluation of the ocular motility, the force duction test, and if possible, exophthalmometry and also a diplopia charting. Imaging is a gold standard where we need to image and we need to examine the axial, the coronal, and also the sagittal, so that we can see the fracture in the same plane in all the three sections. But the question is, when do we intervene? So immediate intervention is done, especially in wave of where we have an ocular cardiac reflex. If there's intractable diplopia in the primary case, or you get the inophthalmos, which is rare in case of child, or in case of a severe globe subluxation. However, if there is symptomatic diplopia and the fracture inophthalmos being more than 2, and if there's no ocular cardiac reflex or not a very grossly deformed situation, then we can wait for approximately 7 to 10 days. However, where there's minimal diplopia with good motility, with no significant inophthalmos, we can just observe. So imaging is the gold standard. Like situation like this, you can see when the child looks up, the eye does not move. This is a trapdoor fracture. As you can see here, this is where you can see the inferior rectus has been trapped here, and this is as the fracture has gone back, but the muscle has not gone back and remains trapped, as you can see in the MRI below, and the surgery should be done in order to release it. However, when there's an inophthalmos, how do we manage the situation? So the most important is people are still believing, many of the surgeons still consider the orthogenous bone graft to be the gold standard, because the autogenous material which really revascularizes well. Many surgeons prefer the resorbable plate, but there are different types of resorbable plate, which can be a poly-L lactate, that is the rapid sorb, or it can be poly-D lactide, it can be PDS, it can be PCL, that is polycaprolactone. So there are different types of resorbable material, and there are multiple studies which shows some says that it gets resolved in 2 months, but a very beautiful paper in BMJ by Gangadhar and Stephanie, they have shown that it can last as long as 2 years. So there are different schools of thought, but still I believe that even till today, I feel that when you have a big fracture in the pediatric case, because you do not see much of prolapse of the tissue, you might see a fracture, titanium is still the gold standard because it has a very, very long track record, which has initially started by the craniofacial surgeon. Has a very good tensile strength, and most important, you can do a molding, you can do a 3D contouring. And usually in children, we do not prefer the Medport because it has got multiple disadvantage, hematoma being one of the major disadvantage. And you follow up is difficult because they are very radiolucent, the Medport sheets. And situation like this, if you look at this child has come with a frontal bone fracture. And the cause of the frontal bone is traumatic, where you see a pellet. So these are the situations is challenging, because we as oculoplastic surgeon at times are a little scared to touch the frontal bone, because we know that when the frontal sinus it bleeds, it's very difficult to control the bleeding. So this situation where you have to use something to a navigation system, because in the navigation we have an advantage. I'll show you. Yeah. This is, you can track it, you just need to follow the tunnel, and if you the point of entry and where exactly you want to target, with a very, very minimal manipulation, you can take out the pellet without causing much injury to the adjacent structure, and also you can salvage the eye, as you can see in this child. So, but this case I really want to share, because I was discussing with my fellow, I thought that it is worth sharing with everyone how beautifully this case has been managed. She's a 14-year-old girl, as you can see that she had an exotropia, and there was a FDT2, And also there was also a MR tuck that is being filled, and she had diplopia in all the cases that you can see here. And when the investigation has been done, this is a medial wall entrapped fracture with the intramedull rectus. So in such situation, you also need the help of the ENT surgeon, and that has been managed so well. As you can see here, this is the muscle that has been entrapped. And if you look to this slide here, this is how initially a peritomy has been done, and then this has been followed by exposure of the medial rectus. And then the ENT surgeon comes into play. And when you pull the muscle from the orbital, from the ocular side, you can see this is the muscle that has totally been prolapsed into the posterior ethmoid sinus, and how beautifully it has been repaired with the septal cartilage. So this is something where the role of the ENT surgeon is very important along with an ophthalmic surgeon, and beautiful results. Just finish in 1 minute. And sometimes what I have mentioned, the NOE fracture, these fractures are real common in the children, though initially I was also not aware. But when I have gone through my literature, I have seen that even the advanced type, where you have the type 3, the comminuted is very common, as you can see in the child having a very bad NOE fracture. So this is also sometimes you have to do to know the volume. I sometimes use the mirroring and do a navigation, and you need to repair, but here you need to give a volume, because there is almost a globe subluxation. There's also dystopia of the medial canthus, and this is what is the empty. This is the empty B plate that I usually prefer in such children, and along with it, you also go for the management of the canthal dystopia. And this is how he looks after approximately a month following surgery. So to conclude, the changing anatomy and the physiology of the pediatric craniofacial skeleton gives unique characteristic to the pattern and the clinical presentation of pediatric orbital fracture. And these factors really determine the management, whether we should go conservative or we should go for surgical. Thank you very much for your patient hearing.